questions in the chat. Please use the Q&A. That way I'll know to go in and receive your questions so that we can share it with the group. So you've already met one of our panelists by that great video, Garen Wilson, but actually he's last in our agenda today. He'll be batting cleanup. So I do want to introduce you to our awesome panelists, and this is the order that they'll be speaking. Dr. John Stewart has a national reputation for multidisciplinary research, and he's been recognized by the National Cancer Institutes with a Cancer Clinical Team Research Award. He's now Associate Director for Clinical Research at the University of Illinois Cancer Center. And he's going to set the stage for us this morning by giving us an overview of inequities in cancer and the unequal burden of cancer in communities of color. Then Dina Darlington is a tremendous advocate for equity, and particularly for the role that industry can play in convening stakeholders to find solutions. She's the main architect of Amgen's Health Equity Summit, and she's also an active member of NMQF's Cancer Working Group. So we're excited to hear from Dr. Stewart and Dina. Then Portia Reddick-White is another amazing advocate from the Campaign for Tobacco-Free Kids. So she'll be talking about the impact of tobacco in communities of color and efforts around prevention as well as cessation to reduce disparities. Then Shashiko Staples is another terrific advocate for access to care. So she'll be sharing the efforts of ACS CAN to improve Medicaid policies and benefits and to increase use of preventive services and enable earlier access to cancer diagnoses and care. And finally, Garen, you've already seen him. He's very photogenic in the film and on our screen here today too. But he's, as you can tell, I think from the video, really an untiring advocate for ensuring that we get adequate and appropriate representation in our clinical research, so that, as he said, when we go to our doctor's office and are considering different options, we know that those have been tested on people like us. And so we want to make sure that everyone, and particularly communities of color, are represented in research. So just our format's a little different than maybe some of the other sessions you've seen. Each panelist is just going to give some introductory remarks for about 5 minutes, and then we're going to go into our Q&A. And the option again, or what we're looking to do is to have 15 minutes of Q&A with you all in the audience at the end. So without further ado, then I will wait. I have to share my screen. I have some opening remarks. Give me 1 second. Here we go. But don't look at the last slide. Let's get to the first slide and get it on the presenter mode. So here we go. So this is what the National Minority Quality Forum is all about. We are really advocating for better cancer outcomes through data-informed collaborative networks. As you heard Garen say, this is an effort that's going to take collaboration. We've talked already about our panelists, and I wanted to let you know that with NMQF, we have a cancer working group, and this is how we go about convening and coordinating with multiple stakeholders to drive better outcomes. So just to mix things up a little bit, I'm going to start over at the right-hand side of the screen. Many of you may know we've got claims data. We use Medicare and Medicaid claims data to help understand what's happening with Medicare beneficiaries, Medicaid beneficiaries in terms of their access to care and the type of care they're getting and what's being treated. And we use that within the Cancer Working Group to help inform our activities. And then we focus on patient and community engagement. We base our index in this platform called mypalc.org, but we are also working on convening stakeholders to really uncover what are best practices, what are frameworks we should be following to make sure that we've got representation in every activity, but particularly in clinical research. et cetera. So we do that through our community engagement sort of work stream within the Cancer Working Group. Then you might have heard Laura Lee Hall yesterday talk about the work of sustainable healthy communities. And so she really takes up sort of the quality improvement in education activities that we contribute to related to cancer. And so Laura Lee's been leading 2 screening efforts, one around lung cancer screening and one around prostate cancer screening. And those are in the high prevalence areas. So lung cancer is an activity to engage primary care physicians in screening in Kentucky. And the prostate cancer screening project was gotten started this year, and that's with partners in North Carolina. And then finally, we focus on diversity and inclusion, and that's particularly in research. Last year, we had a couple of papers published around what are the clinical trial sites that are really good at accruing and retaining minority populations in clinical trials. What are their best practices? And so we published those papers and called them centers of excellence. And this year, we're going to continue on that work and try to spread the word about those best practices to other sites and help sites evaluate their own ability and capabilities to do those best practices. So that's the type of work we're doing in the Cancer Working Group. And just a little commercial, we invite you to join us for that. Now to our topic today. Geography matters. So when we talk about cancer care in the community, we're not just talking about the tumor type community, but we're talking about geographic community. And so as an example, nearly 80% of lung cancer cases among Medicare beneficiaries occur in 20% of US zip codes. And we also know that more than half of people living with cancer really receive their treatment in their community setting. And some estimates I've heard even go as high as 80% of people are treated in the community setting. So it matters. It matters where you live. It matters where you get treated and what treatment's available to you in your community. And just to take it down to another level, we really have to be thinking about how to tailor our solutions to community level needs, because even within the same state, we can see that there's still a distribution of patients, around a given state where people are clustered more in one area, maybe than in another. And that's information we really need to have when we're thinking about solutions that will reach the most people. So that's just a quick setting of the stage, a little bit about NMQF Cancer Working Group and a little bit about our topic now. And so without further ado, I'll hand it over to Dr. Stewart.
Great, thank you so much, Mary. Okay, so I will start sharing my screen here. So good morning and greetings from the Windy City. And my charge this morning is to discuss the unequal burden of cancer. As a subtitle, The Numbers Don't Lie. And so I'd like to frame the conversation in terms of really where the numbers are and really to put a context around our approaches to cancer disparities moving forward. So it's clear that there are inequities in cancer incidence and mortality. Shown here are data from the SEER Surveillance Epidemiology and End Results Group that shows that if we look at cancer deaths for males, African-American males, they're significantly higher than those of white males, and the incidence is also higher. Similar results are seen between Black and white women with cancer. So if we think about the conceptual framework for understanding disparities in cancer, I think it's important for us to understand that there are domains of influence, such as biological, behavioral, physical, sociocultural, and healthcare systems. And then there are also levels of influence that include the individual's impact on their healthcare, interpersonal relationships and interpersonal function, the community, and society at large. And these outcomes are actually seen at both the individual, family, community, and population health levels. This is a framework that, again, has been provided by the National Institutes on Minority Health and Health Disparities. So let's start to really drill down to the unequal burden of cancer as represented by the numbers. So if we think about breast cancer, what we'll see is number one, that the incidence of breast cancer in African American women, shown by the blue triangles, is a little lower than that of white women. However, it is also higher than our Asian Pacific Islander um, um, and Hispanic populations in Native American individuals. But if we look at mortality, we'll see that there is a dramatic difference in mortality for African American patients versus white patients. So per 100,000 population, Blacks suffer 26.9 deaths, whereas whites suffer 19.4 deaths. Now, some would consider that this difference in mortality could be related to stage of presentation, also related to the biology of tumor. So I'd like to draw your attention to triple negative breast cancer, which has been considered to be a major biologic driver of disparities in cancer outcomes. Shown here is data from Siddharth et al. That shows that there are multifactorial contributors to triple negative breast cancer, including socioeconomic factors, genetic risk factors, and a high prevalence of obesity in the African American community. And each of those factors actually have biologic consequences that can be seen primarily in the genetic risk factors and high prevalence of obesity. I would be remiss in noting that recent data suggests that our zDNA or our zip code DNA actually has significant impact on our outcomes in cancer, as demonstrated by differences in behaviors of tumors driven by zip codes. Now, it is well accepted that there are also significant disparities in prostate cancer incidence. As shown here, the incidence of prostate cancer per 100,000 Black males is 180.9 versus those of white males, which is 108.7. There continues to be, however, a difference in mortality. So per 100,000 African Americans, we have a death rate of 36.4, which is slightly more than twice that seen in whites. Fortunately, this disparity in mortality is shrinking relative to where we were 25 years ago. However, it does persist. So as a Howard alum, I would be remiss without talking about the fact that colon cancer continues to have a significant role in the landscape of African American health. As we know, this is Chad Boswick, who died of colon cancer far too early. And if we think about his case, what we'll see is that there is a higher death rate per 100,000 in African Americans relative to white patients. Now, if we look at these data, one would say, yeah, it's double that in patients 20 to 24. However, again, these are small numbers. But what does become very apparent is that as we move to 30 years of age and higher, this disparity in deaths per population continues to increase. And again, we begin to see statistically significant increases at age 30, and they continue throughout. And so, many people don't speak about gastric cancer as much because its prevalence is not as high as breast, prostate, lung, and colorectal cancer. But shown here is that African Americans continue to have a higher incidence of gastric cancer relative to the general population. And we also have almost double the death rate for gastric cancer. And finally, I want to draw your attention to an area that I've had a research interest in for over 20 years, and that is that of lung cancer. So if we think about the incidence of lung cancer, we see a clear break between the incidence of lung cancer seen in males and the incidence of lung cancer seen in females. And what we'll notice is that African American men actually have higher incidence and higher mortality of lung cancer relative to white males. If we look at the incidence and mortality of Black females versus those of white females, we see that Black females actually have a slightly lower incidence and a lower death rate from lung cancer. So these data actually provide us a framework to consider how we should move forward in understanding health equities and health inequities in cancer. So I say that there are 4 important points that we need to take from our conversation today. And first is that we have to have an explicit acknowledgement that structural racism and all of the untoward consequences of structural racism actually contributes to cancer inequities, whether we think about it in terms of stress, environmental exposures, difficulty in accessing healthcare, and even implicit biases in providers that we have to acknowledge that structural racism has had a significant key. Secondly, we have to move toward research that targets mechanisms of cancer disparities in all domains of influence. Again, that moves from biology all the way down to understanding how health systems actually impact cancer health disparities. And third, we have to support the community to bench model. Now, this is a flip on what many people consider the bench to community model. At the University of Illinois Cancer Center, we actually take questions that are driven by our community advisory board, and we move those questions to the bench to understand basic mechanisms that impact our catchment. This is important because it allows us to drive a catchment relative research program. And finally, show us the money. At the end of the day, none of this really will move forward unless we have significant grant money from the federal and state level to really begin to have an impact on not just recognize the presence of cancer health disparities, but also understanding ways in which we can actively reduce these disparities. Again, I'd like to thank you for your attention, and I look forward to questions during the Q&A session.
Thank you very much, Dr. Stewart. So our next panelist is Dina Darlington from Amgen, who's going to talk about the role that industry can play in convening multiple stakeholders.
Sure. Thank you so much, Mary, and to the National Minority Equality Forum for inviting Amgen to speak on today's panel. I'd like to chat a little bit about the work that Amgen has done in the space of health equity and engaging stakeholders, particularly those stakeholders that are from the patient advocacy community, but also from our professional association. The health equity is 7 years old. This year, we're going into our 8th year. It's nearly a decade old, and we really thought it was important early on, particularly through the launch of a multiple myeloma, a product used to treat multiple myeloma, but also liver cancer. And we saw a significant level of disparities within those disease states. So we took the initiative to really convene our stakeholders and bring on community speakers that could speak to the issue of disparities, but also we brought in a number of speakers throughout the various community universities to really highlight their expertise with the full intent of looking at this health equity as a stepping stone to action. What can we do as within the health ecosystem as partners and stakeholders to really address health disparities? This, as I mentioned, this has been going on for 8 years, and the approach that we've taken is to engage stakeholders, particularly those from the patient advocacy community, bring them in and allow them to share what their various disease state has experienced from a health disparity standpoint. We felt that oncology was super important for us to focus on in light of the multiple myeloma and the liver cancer. But over the past 7 years, we have expanded beyond those disease states. We also thought it was important to bring in community leaders right here in Washington, D.C. We've brought in community leaders like Dr. Lucille Adams Campbell of Georgetown. We've brought in experts from Howard University to have a discussion about the community, the role they play within the community. And we've also brought in professors, academia across the country to really share their expertise as well. And I think more importantly, not only their expertise, but how they have been impactful. What has worked for those leaders in the health disparity space? Another issue that we felt was important to address was the gap we saw with various patient advocacy organizations, and that they typically did not engage on the topic of health disparities. And we really wanted to help support or fill that gap by engaging them with groups like National Minority Equality Forum and other community organizations that focused on health disparities to really look to a partnership patient advocacy organizations working with community organizations and learning, both leveraging the resources that they have, the tools that they have in place, but also bringing them together to speak in one unified voice around health disparities, but also to support one another on policy issues. And then finally, what we felt was really important was to engage diverse disease states and allow them to learn from one another. Oncology has really been a leader in the space of advocacy, but also from a health disparity standpoint. So we wanted to bring in oncology, patient advocacy organizations, stakeholders to teach and lead the way with other disease states. And we found that this has been very impactful because it's allowed these stakeholders who traditionally have not really engaged in projects like, say, a barbershop program, where African-American barbershops are engaging with educational material, but also having a place and a space to digest that information to support outcomes from a health disparity standpoint. So these are just a few of the areas that we've looked at within our Health Disparities Summit. In the light of George Floyd, we at Amgen intend to do more in this space, and I think that this is a great launch pad for us to really look what we can do from a social determinants of health and from a research standpoint as well, to try to look at new arrangements from a value-based arrangement, but also to partner with groups like payers, partner with our stakeholders in the patient advocacy and the professional association communities to really be impactful in that space and look to what's needed in more vulnerable communities. And I'll just end my discussion by making a shameless plug for the upcoming Health Equity Summit that we're having on October 22nd. We are having a keynote speaker of Harriet Washington. She's the author of Medical Apartheid. We're excited to have her as a guest. We have our, as part of a fireside chat, we'll be having our CEO is a participant and a panelist with Dr. Barat of Xavier University, and also Dr. Shrag, who is the CMO of Humana. Again, we believe partnership is so key to this discussion, and we think that if we, the stakeholders within the healthcare system and within the health ecosystem, if we can come together, not only dialogue about the topic, but more importantly, come together with some really solid, actionable items that we can do as a whole, that we can make some headway into this space. And I'll also note that at that Health Equity Summit, we'll also have a panel discussion on diversity in clinical trials, which is always a very key and important topic for discussion. But we also want to be very relevant and sensitive to the illumination that has occurred with COVID and really highlighting the already existing health equity or health disparities that already existed. So we'll have a panel discussion with with an actual patient that will speak to their experience with COVID, but then key stakeholders in that dialogue to identify what should we do moving forward in that space. So with that, I will hand it back to Mary. And Mary, again, thank you so much for including Amgen in this dialogue today.
Thank you, Dina. It's always, interesting to hear, where you're at, where the industry is at in terms of convening people to start to address those issues within your center. And so thank you for telling us more about the upcoming summit, because I think it will be a place for many people on this call to continue the dialogue and get to action. So one of the things that you talked about was bringing in speakers from the community. And so I think that's a natural transition to our next speaker, Portia White, who is at the Campaign for Tobacco-Free Kids. And we'll talk about what are the needs in the community and specifically the role that tobacco plays in disparities in cancer care and how we can address that. Portia?
Thank you, Dina, as well as John and Mary. I'm going to share my screen as well, and and present a bit about where we are with tobacco. So, are we there? Screen sharing there? Perfect. So, with what's going on in the community with tobacco, I will say that we believe, first of all, that bringing everybody together in the community, whether that's patient advocates, whether that's a group of folks who really want to support the causes in the community that lead to these health disparities. We are very concerned with that. And so we want to bring attention to the fact that tobacco, yes, is a major contributor to these three leading causes: heart disease, cancer, stroke, and diabetes is the fourth leading cause of death among African Americans. The risk of developing diabetes is 30 to 40% higher for cigarette smokers than non-smokers. So that is where we are within the community. And AACR has actually recently released their Cancer Disparities Progress Report. And in that report, as you will see here, actually the American Indian, Native Alaskans actually rank highest with a 32.3% usage of tobacco use in products. But African Americans are right there along with 19.3%. And then you have also the income as well as the classification of sexual orientation as well. But you will see that 19.3% is, well, pretty much in the middle here regarding tobacco use and how it affects African Americans, Black Americans, and the tobacco use of the product itself. So lung cancer, of course, with what Dr. Stewart has actually provided earlier, lung cancer with the death rate is very high, very prevalent within the Black males specifically, but Black females as well. And you'll see by this chart that Black males actually, even though this was back in 1920 and 2010, and actually the peak was in 1990, it's declining, but it still ranks high among all the other ethnic groups. So why is this happening? Well, for years, for 50 years or more, actually, there's been this decade of targeting of advertisement from the tobacco industry itself. They have targeted the African American community specifically with some of the ads. Actually, they were one of the first, to be honest, to really utilize actors and actresses, which was great for the community. But at the same point, I believe it was a subliminal approach to gain access into our thoughts and our processes of being accepting of their products. Furthermore, they did sampling, mobile van products, music event sponsorships, the targeting, magazine advertising, and they continue with this point of sale targeting as well as the music and event sponsorship in our communities. So we have been targeted by the tobacco industry. And a part of that, I believe, is the institutional racism that constantly it does occur, allowing the tobacco industry to remain prevalent within our community. So the problem with that is that menthol and cigarette use is highest among African Americans and youth smokers. So 85% of African American smokers use menthols compared to 29% of white smokers. And of course, over half of youth smokers aged 12 to 17 use these cigarettes as well. And so 7 out of 10 African American youth smokers use menthol cigarettes. So menthol is actually a product that is easier to get hooked on. It's harder to quit. And that's why you see a lot of folks in our neighborhoods, in our communities, who are really stuck on tobacco use from the traditional method of cigarettes, as well as the non-traditional now of e-cigs, which is prevalent. And also cigars among our youth is really high, cigar use. So African-American youth have the highest rates of cigar use. This should be just alarming to us. We not only, have the 17.7% use of cigarettes, but we have this 12.3, which rates higher than the Hispanic group or the white group of cigars. Sorry, I had it backwards. This is a cigarette, that's e-cigs. So, with that being stated, this e-cigarette campaign and even the hookah, which is really prevalent within our community as well, these are all products that actually are products that we believe and we know that actually affect the disparity within our communities, within the cancer and other morbidities that exist. So what are we doing about that? So the Campaign for Tobacco-Free Kids actually sponsored and was very supportive of the Pallone bill, HR 2339, which passed the House, has not passed the Senate, won't pass the Senate, probably this Congress at all. But it's a very important step in addressing some of these issues. It will prohibit the online sale of most tobacco products, the sale of flavored tobacco products, which, by the way, are those things that really are hooking our neighborhoods and hooking the folks that we care about. Furthermore, and I flipped onto the page so you could join us, this whole outreach and what we're doing, we want to help to curb this. We want to curb this through all policy making. We want to make sure that we are raising advocates. Right now, our focus for sure has been on youth advocates, as our title says, Campaign for Tobacco-Free Kids. But in order to do that, we know it takes a neighborhood. We know it takes a village. And so we are, actually working outside of those resolves and reaching out to others so that we can join partnerships together to build forces to really combat the tobacco use within our community, based on the fact that, these morbidities do exist. Furthermore, I would say that there is a bill right now that Congresswoman Rochester Blunt has actually brought forth, and as well as, the corresponding senator in Delaware, to support tobacco cessation, a bill of tobacco cessation, and helping that to be part of a Medicaid prescription. Right now, pregnant women, really, they are covered when it comes to Medicaid cessation efforts, but everybody else isn't. So we want to make sure that that is covered, and within this bill, it would allow that. So I ask you to reach in, become an advocate with us, to join forces in the community to fight against the evils of tobacco that actually are prevalent in what's going on in our society right now, as far as helping to curb the morbidities, specifically this morbidity of cancer that we're very concerned about. And I want to thank you for inviting me to speak today, and I look forward to any questions that may come about.
Thank you very much, Portia. And so sort of sticking on that policy angle a bit, I'd like to introduce Shashiko Staples Miller from ACS CAN to talk about Medicaid policy.
Thank you, Mary, and good morning, everyone. As Mary said, I'm going to spend the next few minutes talking a little bit about the Medicaid program and the role that this program can play in helping address cancer disparities, but even more specifically, a broad range of the disparities that lower income individuals in this country face. What we do know is that health and racial disparities, as well as cancer disparities, are really experienced most by those individuals who lack access to quality, comprehensive health insurance coverage. And the Medicaid program historically has provided that coverage to a portion of the population that largely excluded screening age eligible adults in this country. And with the passage of the Affordable Care Act, states were provided the option to expand eligibility for their Medicaid programs to cover very low income parents and low income adults, some of whom may be single or those who have children who are over the age of 18. And this coverage expansion really was a game changer in terms of addressing some of the known disparities that people who are uninsured face when it comes to prevention and early detection. A few quick points that we know is that people who are uninsured, they have less access to prevention and early detection services. They are lower utilizers of screening programs or screening services. And that's of particular importance for many of the cancers that were highlighted in Dr. Stewart's initial presentation, as well as those remarks that Portia just provided around tobacco use. And if you would reflect back on the slide that that Portia showed, while you saw those breakdowns of the use of tobacco products by race and ethnicity, there was also a slide that was in there, a graph that was in there that was in green. And it indicated that lower income Americans have significantly higher use of tobacco products. And they also have less access to tobacco cessation services, as Portia mentioned. And it's not just tobacco cessation services, but also many nutrition and weight loss management programs that can help individuals really reduce the likelihood that they would develop cancer. And if one is covered through Medicaid and living in a state that has expanded eligibility for its Medicaid program, then folks can access those services. We've also found that data indicates in states that have expanded their Medicaid programs that there's much higher utilization of screening services, and we're seeing incidence rates actually go down. Data that has started to come in over the past 2 years is also showing some impact on cancer mortality in states that have expanded their Medicaid programs. The good news is that there are 38 states that have now expanded eligibility for Medicaid, providing more than 15 million people in this country, lower income folks in this country, access to health insurance coverage that includes a significant number of people of color. But what we still know is that 12 states and some really big states, one of which I'm tuning in from, Georgia, has not expanded Medicaid, leaving upwards of 5 million people without access to health insurance coverage. And so many of the benefits and services that are critical in the fight against cancer and critical to preventing cancer altogether. One thing that many people don't understand about the Medicaid program is that it's unique in that it provides quality, affordable, and comprehensive coverage that spans the cancer continuum. And so this is not only coverage that can help you detect cancer early, but it's also coverage that will help with diagnostic testing, treatment services, and survivorship care. So it's one of the things that I would definitely want to leave everyone with is to make sure that you learn a little bit more about the Medicaid program, and I'll tell you a way that you can do that by partnering with the American Cancer Society Cancer Action Network. Last spring, we launched a public education project called Medicaid Covers Us. And it is a project that really is designed to help people understand the basics of what the Medicaid program is. And we do so in a way that really tries to charge many of the misperceptions and stereotypes about Medicaid. And next week, next Tuesday, actually, we'll be having an event that I hope many of you will log in and join us at, that's really focused on an exploration of the impact that the Medicaid program can have on communities of color. And we're specifically zeroing in on a majority Black county in the Black Belt of Alabama that highlights the role that Medicaid could play in that state, especially since it's a state that has not expanded eligibility, to help the overall health and well-being of the residents of Greene County. But then it also further explores the impact that Medicaid has on hospitals and health systems, and then more broadly on the economic health of communities. And as part of the project, we were able to do a short documentary film that highlights Alabama as well as communities in Kansas and North Carolina. And during the event next week, we will do a premiere of a very short update on that Alabama film that focuses on the impact that COVID has had on Greene County, Alabama, and the lower income population. We know that COVID has exacerbated many of these systemic disparities that have existed. And this film and the conversation that we'll be having next week will explore that a bit further. And for any of you real Medicaid nerds out there, Dr. Jamila Mishner, who is an associate professor at Cornell University and the author of Fragmented Democracy, will be one of our keynote speakers. And Mary will show a slide that has some registration information about the event at the end of this panel. And I think there's going to be a link to the registration in the chat. So we hope that you will join us and learn more about Medicaid and how it can play an incredible role in addressing many of the cancer disparities that we know exist in this country. So thank you, Mary, and to my fellow panelists for giving me a little bit of time today to talk about Medicaid. And I look forward to your questions during the Q&A.
Thank you very much, Shashiko. And I will say that, I'm prepared. And we did put the bit.ly link for registration in the chat. So for anyone who's interested in that session next week, I think you said it's October 13th. Is that correct? Anyway, the link to register is in the chat. You could go in there and snag it and copy it now, pop it in your calendar. But there will also be a slide with our closing remarks as well. So you'll have another chance to write that down. But now I want to introduce Garen Wilson. We've been talking mainly about kind of the active disparities in kind of practice and disease incidence and prevalence and our existing policies around tobacco and Medicaid. But we haven't really talked about research and how important research can be to reducing disparities, later in the time frame. So research is about the future, and so we're going to toss it over to Garen to tell us, what does the future hold?
Thank you, Mary, and good morning, everyone. Let me pull up my screen here. I appreciate all the introductory comments from my fellow panelists. I think they were quite informative in highlighting a lot of the issues that we're grappling with now. I think I'll spend my introductory comments speaking a little bit about where we're headed in healthcare and some emerging trends that are really promising that we should all be encouraged by, but then also talk about the importance of research participation to ensure that all communities benefit from the best that healthcare have to offer, and some of the things that we can do now to advocate for access to that quality environment. And then also kind of close on some signals that we can get this done and we can start to resolve these disparities that we see in the clinical research setting. It's possible, and I think that should give us all some confidence that we can carry forward. So, as you all can appreciate, we are in a pivotal moment in healthcare. If we think about the opportunity to provide the right treatment to the right patient at the right time, is more possible now than it's ever been. And some of these trends that you see illustrated on this slide speak to why we have this confidence in healthcare and those that are in the research and development space. With some of the emerging diagnostic procedures and tools that are at the disposal of clinical care teams, we have this increased understanding of disease biology and our ability to understand disease biology, compare that against human biology, and use that to guide treatment decisions is more precise and more effective now than it has ever been. So that's something that's really encouraging, particularly in the cancer care setting. If you think about how educated and empowered patients are with the use of their cell phones, the ability to understand their diseases, access information, ask questions to their care teams, be able to track their disease over time, with the use of technology. Patients are educated, they're asking for more, they're demanding more. We need to make sure all patients carry that same enthusiasm for their health and their well-being, both of themselves and of their families. We've talked about the technologies. I mean, the power of the phone to just capture a person's disease experience over time, our ability as a healthcare industry to capture and take all that information that we're seeing from patients and unlock new insights with the use of tools such as advanced algorithms and artificial intelligence. We are smarter than we have ever been in our ability to understand disease and make really smart decisions and make the right interventions to ensure that we push towards the best outcome. So it's really exciting, but it also requires a new type of partnering within the healthcare environment to ensure that we are working with people that have the right kind of trust, the right respect, and the right connection to the community to make sure that the technologies and the investments in personalized healthcare truly connect to all of us, the patients that want to benefit from these emerging technologies and the promise that the future holds. And I think fundamentally at the end of the day, all of us really just want more value out of the care that we receive from our teams and the medicines that we take. And so we're all demanding more value-based, outcome-driven healthcare. And I think that's really what the promise of personalized healthcare has to offer, and something that we should all be encouraged by. So we've talked a little bit about some of these trends. Genomics, information that we have about our own human biology and our understanding of disease biology. If we look at all the electronic medical records that are capturing a patient's lived experience with disease, digital technologies, advanced imaging, digital pathology, a lot of these modalities are generating a lot of data, a lot of patient information about a person's experience with disease. And I think the opportunity that's in front of us is to couple that with emerging technologies and information technology, our ability to hold all of this information in balance and to use new health algorithms that are sophisticated that can evaluate all this information, structure it appropriately, and help deliver this high resolution view of a patient and their disease. I think over time, as the art of medicine has progressed, we've made treatment decisions that weren't benefiting from this high resolution view that you see with the patient on the far right. That's really where we are now. We're knocking on the door of this high resolution view of a patient and their disease, which will guide treatment and ultimately help improve outcomes. But fundamentally, one of the big issues that we have in this environment right now is that communities of color haven't historically participated in the research process that generates a lot of the information and the data that we use as an industry to design personalized healthcare. And if this data, this experience is not factored into the design of personalized healthcare, one could question the ability for us to achieve this high resolution view of communities of color and their experience with disease. And this is something that we have to change. We don't want to, design a really positive and encouraging and exciting future of care if it's going to be something that exacerbates the disparities that we already know exist, in healthcare right now that our panel has been highlighting. So this is something that we have to change. And I think fundamentally the way we are thinking about doing this as an industry, it's multifactorial. There's a lot of different ways that we are approaching this. But one of the main areas is ensuring that all patient groups have access to the clinical research environment. It's important for two reasons. Particularly in the cancer care setting, clinical research participation is guideline recommended. It's a guideline recommended treatment approach because the quality of care in the environment is high. I mean, you have great doctors, you have great clinical teams, you have a lot of wraparound support for patients. So fundamentally, this is a patient access issue in the cancer care setting. And participating in clinical trials has been shown to improve outcomes. So the fact that, if you look at the illustration on the far right, Black women have a higher cancer mortality rate than white women, and yet only 6% are participating in clinical trials. That illuminates the disparity that exists, and that's something that we have to change. So fundamentally, our aspiration as a company, Genentech, and as a broader industry, something that we're in discussion with our industry peers, is that we ensure that we have more representative patient populations in clinical research to provide access to high quality care now, and then also to help enable the promise of personalized healthcare in the future. And that's something that we're really driving towards. And I think we're seeing that this can be done, and we're proving that it can be done at Genentech. So, we've been talking about the pandemic and how COVID-19 has exacerbated disparities and in some ways poured gasoline on an existing burning platform that was disparities across the healthcare system. When we saw this, we realized that, we had a molecule that was being evaluated in the COVID-19 pneumonia setting to help address some of the inflammation that was present in the lung environment in patients. We saw that communities of color were being disproportionately impacted in terms of prevalence as well as outcomes. And we stood up at trial, the Impacted trial, which stands for Evaluating Minority Patients with Actemra, to evaluate Actemra's potential role in addressing some of the disparities that we saw in that environment and addressing the inflammation within the COVID-19 pneumonia setting. We did the study, stood it up in record time, enrolled it, got over 370 patients enrolled in the study. 85% of those patients were from communities of color, Black, Latinx, Native American, a tremendous accomplishment for science in proving that this can be done. But fundamentally, a couple of weeks ago, the study read out, and actually we hit the primary endpoint. And tocilizumab was able to demonstrate a 44% reduction in patients progressing to mechanical ventilation. So I think fundamentally this is a game changer in terms of industries, number one, committing to do and tackle disparities in the research setting, addressing inclusive research, which is important, putting the resources into the environment, working with new clinical trial sites, working with patient advocacy organizations, working across the entire spectrum to partner so that patients understood what this was all about. They felt educated, they felt like they could make the right decision. And fundamentally, this will both guide current treatment decision-making and also guide the scientific enterprise to understand that if industry commits to this, that we can make this happen and this can be done. So I think this is something that we're proud of. I think something that the industry collectively should be proud of and can learn from, and something that we're excited to continue the dialogue on. So with that, I will turn it back over to Mary. I think we will open this up to a Q&A. Thanks, everyone.
Thank you, Garen. Yeah, we do have a few minutes left for Q&A, and I'm going to jump because we've had some active Q&A, asking and answering going on. So I want to jump to the remaining unanswered question in the Q&A, and then we'll come back to some of the prepared questions. But so there's a question here from Shanta Chambers. As we think about all of the stakeholders in the healthcare ecosystem, how do we ensure that we don't price paralyze individuals in their pursuit for comprehensive quality healthcare? What do we do different? And so it's interesting because we've been talking a lot about sort of risk factors, health risk factors, but this is a financial risk as well, right, for patients. And Shashika, would you mind if I sort of toss that question to you to start? Because you really talked about income as a driver of one's risk factors, but also their utilization of healthcare services. Mm-hmm. So why don't we start with you?
Yeah, I think there's, specifically in the Medicaid program, one of the things that in my experience has been this challenge around individuals who qualify for the program demanding quality care from their providers. And oftentimes, we're not seeing Medicaid enrollees be really vocal advocates for themselves. In many instances, they're just, and we found this from a lot of messaging research and focus group work that we've done, including some focus groups with Medicaid enrollees themselves. They've said, we're just happy, we're just grateful that we're covered. We're just grateful that we can get some type of care. And so this demand that most of us as consumers of employer-sponsored coverage, where we're seeing a portion of our paycheck taken out every month to pay for our care, or we're paying out of pocket for that care, we're constantly demanding more. We're, as Garen described, we're different types of consumers of health insurance, and have a higher level of expectation in terms of the quality of the care that we're going to get. And so it can be challenging with Medicaid enrollees in particular, who are, I would say, oftentimes they don't feel empowered to demand more, or call into question, say, an authority figure, a physician in their community. And so what we try to do as advocates is ask the state to demand more of the providers of that care. And so as an example of that, it's really trying to focus on quality improvement programs and better care coordination when it comes to individuals who are dealing with cancer. And we have found that if you can demand more through better care coordination, higher quality improvement programs, some of which can have a carrot and a stick built in, where there's say plans needing to meet certain HEDIS metrics in order to earn a bonus. So a quality incentive that's built into managed care contracts with state Medicaid agencies, then we can start to see the quality of the care improve. And one of the things that I did want to mention that ties back to much of what Garen covered is around improving access to clinical trials. And it's really fragmented in this country as to whether a lower income individual can gain access to a trial without risking them having to pay some other out-of-pocket cost related to any care that they might need directly related to the trial. And so, as an example, in Illinois this year, we worked on a bill that that passed and was signed into law very quickly by the governor, that actually ensures that people who are enrolled in Medicaid can enroll in a trial, and they will not experience any out-of-pocket cost sharing for any of the care related to that clinical trial. And so it's those types of barriers that do exist. And I think that we as advocates, both from the industry side, as well as other patient advocates and providers like Dr. Stewart, can really lend our voice to help better describe the type of care that's needed, and setting higher standards in terms of what plans and providers should be doing to make sure that quality is there.
So I'd like to add, so great comments. So there are a couple of, I guess, data points that I want to add to the conversation. So number one, it is well recognized now by multiple sources of data that patients actually receive better clinical care when engaged in a clinical trial relative to what they would receive while receiving standard of care. And so that is a message that we really need to put out in thinking about clinical research as a care option for our patients. When I was a third-year medical school student at Howard, so I guess that might have been around 1992, we were out doing some community work, and we were just happy to have our little white coats on and taking blood pressures. And a woman astutely noticed, she said, you guys should come see us when you don't need something, i.e. we need to really be engaged in the community around really relevant health issues so that we create that sweat equity with the groups. So when we begin to think about clinical trials and roll clinical trials out, that they actually understand that we are partners. One way that we have really approached this again is by having a really active community advisory board and participating in programs such as the Citizen Scientist Award that's being funded at present to, again, really ask research questions that are relevant to our patient population. And again, I think that will really create inroads to increasing participation in clinical trials.
Thank you. And you really brought up the idea earlier in your remarks about the catchment area. And so for, I think, us to know sites like yours, whether they're doing clinical research or standard of care sort of approved treatments, that you are resources we can go to understand how you're engaging with the community, what needs have come to you through your community advisory boards. That may be an untapped resource for industry, for example, when they're anticipating where to put clinical trial sites.
Right. So there are a couple of things. I guess two more data points I want to provide. So point number one is that from a health system level, we have to make clinical trials accessible to the patients. So that means that patients have to be able to have a smooth in-wrap into the health system, right? So if they call to make an appointment, they don't need to make 5 calls to make an appointment. They need to make 1 call to make an appointment. Secondly, that, as we, so I was previously Associate Dean of Clinical Research at Wake Forest. And so, one of the things I strongly impressed upon people is that we have to have really clean data processes, and we have to have, we need to be able to conduct our feasibility studies like within 48 hours. So if a company calls us and says, listen, we have a trial for patients with head and neck squamous cell carcinoma, with X, Y, and Z inclusion and exclusion criteria, we need to be able to tell them, yes, and this is our population and this is our expectation of enrollment. And so health systems really need to be geared toward that and think of it not only as a service model, but as a business model so that we can increase accessibility of clinical trials to our populations.
So thank you. I'm going to get the, the hook, the virtual hook from the Summit Registrar. I wish we had more time for questions, but as a reminder, we can continue this conversation for those of you who are able to attend the Health Equity Summit that Amgen is hosting. There's a link to that in the chat. Also in the chat is the link to the Medicaid. Help me with the title again, Shishiko. Medicaid is us, or Medicaid helps?
Medicaid covers us.
Medicaid covers us. Thank you. I was going to show slides, but we're running out of time. And I also will offer an open invitation to everyone to please consider joining us here at NMQF and our Cancer Working Group, because that's a very natural place for us to discuss some of these additional calls to action around diversity in research, but also the really important policy work that we're seeing in terms of social determinants of health, specifically tobacco prevention and cessation, as well as the Medicaid issues. So I think I've covered everything. The next session is the town hall. There's a link to that in the chat as well. So hope to see many of you there. And I will just thank you all for participating today. Hope you found this valuable. And I certainly enjoyed having the opportunity to work with all of our experts here, putting this together for you. So thank you very much. And we will see you at the town hall.
Thank you.
Bye-bye.